Today we are going to discuss about interceptive orthodontics. What is interceptive orthodontics? It is the phase of science and art of orthodontics employed to recognize and eliminate potential irregularities and malpositions of the developing dentofacial complex. So, interceptive orthodontics is nothing but all the procedures that are carried out to prevent a malocclusion from progressing into a more complex one. That means an individual might be having a mild amount of malocclusion and we are recognizing it at an early stages of the development and taking all the necessary steps to prevent this malocclusion from progressing into a more complex one. This is called as interceptive orthodontics. Now, there are number of procedures that are carried out as a part of interceptive orthodontics. Those procedures which are carried out in interceptive orthodontics include serial extractions, correction of developing crossbites, control of abnormal habits or intercepting the abnormal habits, space regaining, muscle exercises, interception of skeletal malrelation in the developing dentofacial complex, and removal of soft tissue or bony barriers that can be present in the path of eruption of the teeth. Now, let us look into these interceptive orthodontic procedures one by one. The first and the important interceptive orthodontic procedure is serial extraction. The term serial extraction was coined by Jelgren in 1929. It is described as planned and progressive extraction by Nance in 1940, and this process is popularized in this name in the United States of America. According to Hotz in 1970, the process of serial extraction is called as active supervision of teeth by extraction. In the process of serial extraction, what we actually do is, at a speculated period of time, with a gap or timely interval, we will carry out progressive extractions of few primary teeth in a predetermined manner, and we will guide the erupting succedaneous teeth into a more optimal position in the jaw. That's why it is called as guidance for eruption. Now, as I told you, in the serial extraction procedure, we are actually extracting the primary teeth, thereby guiding the underlying permanent teeth to erupt into a more optimal position. What is the rationale behind this, or what are the supporting concepts behind the serial extraction? Number one is arch length tooth material discrepancy. It is postulated by many others that the major reason behind a malocclusion is deficiency of the arch length or excess of tooth material. So, by extracting few primary teeth and few permanent teeth as a process of serial extraction, we are actually reducing the amount of tooth material, thereby we are equalizing the arch length to the tooth material, thereby avoiding the malocclusion. That means, as arch length tooth size discrepancy is the most common etiology behind malocclusions like crowding, we are actually reducing the amount of tooth material, thereby making the arch length compatible to the tooth material, thereby preventing the malocclusion from occurring. Now, the next supporting concept behind serial extraction is, as I told you, we are extracting the deciduous teeth, say a deciduous molar. Now, there is something called as physiologic tooth movement. That means every tooth in the dental arch, either in the maxillary or mandibular, tends to move constantly to make contact with its adjacent tooth and also to make contact with its opponent tooth. This is called as physiologic tooth movement or physiologic tooth migration that happens in every individual. This happens not only in serial extraction, it's a common phenomena that compensates for occlusal wear and proximal wear. So there is a constant tendency of tooth in the arch to move either occlusally or mesially to make contact with its counterpart or adjacent tooth. The same concept can be applied here. When we extract a deciduous tooth or a permanent tooth like first premolar, as in process of serial extraction, the adjacent tooth and the succedenious teeth will start erupting in order to meet its counterpart in the opposite arch or in order to meet its neighbor in the same arch, thereby reducing the amount of crowding and taking the tooth into a more optimum position in the dental arches. So the presence of arch length tooth size discrepancy and its elimination, and the ability of the teeth to move physiologically, forms a strong basis and supports the process of serial extraction. Now, what are the indications of serial extraction? Can we do serial extraction in any kind of developing malocclusion? The answer is no. Let us look into the indications of serial extraction. The main indication of serial extraction is class 1 malocclusion with optimal skeletal relationship and harmonious muscular system, and presence of arch length deficiency which is not less than 5 to 7 mm. If the arch length deficiency is less than 5 mm, there is no need of serial extraction. But if it is more than 5 to 7 mm, if the arch length deficiency is more than 5 to 7 mm, then it is an indication for serial extraction. And as we know that some kinds of malocclusions like mild crowdings will be get adjusted or relieved with the growth of the jaws, whereas in some cases where the growth cannot correct the malocclusion by itself, those are the cases where we can go for a reduction of tooth material and make the arch length compatible with the amount of tooth material that is present, thereby eliminating the malocclusion. So insufficient growth to mask the discrepancy between tooth material and basal bone or arch length is an indication for serial extractions. And patients with straight profile and pleasing appearance are the only indication are only indicated for serial extraction, whereas patients with severely convex profile or presence of skeletal discrepancies, these are the patients which are not indicated for serial extraction. So in order to carry out a serial extraction, the person should be having a straight and pleasing profile or aesthetic profile with no skeletal discrepancy and presence of the dental tooth material excess or arch length deficiency which is more than 5 to 7 mm. So these are the patients who are indicated for serial extractions. Now, what are the contraindications for serial extractions, or what are the cases where we should not carry out serial extraction? Those are class 2 and class 3 malocclusions, whether it be a skeletal or dental. It's a contraindication for serial extractions. Patients having a less number of teeth like oligodontia, or reduced tooth size like microdontia, or patients with spaced dentitions, and patients having an open bite and deep bite, presence of midline diastema and space deficiency which is less than 5 mm, and patients with unerupted or malformed teeth like dilacerations, and patients with extensively decayed permanent first molars. These are the cases wherein you should not carry out a serial extractions. If you carry out a serial extractions in these cases, number 1, other complicated malocclusions like open bite and deep bite cannot be resolved by themselves. They need a comprehensive orthodontic treatment. Whereas if you go for serial extractions in cases of class 2 or class 3 skeletal or dental malocclusion, of course you might be able to relieve the crowding, but you will not be able to achieve a optimum occlusion of the dentition. So it also needs a comprehensive orthodontic treatment. And one more thing, if you are going for serial extractions in a patients having oligodontia or spaced dentition, you will further complicate the problem rather than reducing the problem. So these are the contraindications of serial extractions. Now, what are the advantages of the serial extractions? As I told you, serial extraction is a interceptive orthodontic procedure. That means we are preventing a malocclusion from getting more complicated. Thereby, it strengthens the psychological aspect of the patient. It eliminates the psychological trauma of the patient or psychological trauma to the patient, because the malocclusion is relieved at an earlier age of life. And the serial extraction procedure eliminates the need of multi-banded fixed appliance therapy, which is time consuming procedure and costly procedure. Thereby, the patient will be pleased to get the malocclusion corrected at an early age of life by serial extraction procedure. And the cases treated by serial extractions require very lesser retention period, and the result that is achieved by serial extraction is very much stable when compared to that achieved with the multi-banded fixed appliance therapy. So these are the important advantages of the serial extraction. There will be elimination of the psychological trauma to the patient. There will be no need of multi-banded fixed appliance therapy in the later age of the life, and the cost of the treatment will also be less, and the retention period will be less, and the stability will be more when compared to fixed appliance therapy when you carry out a serial extraction as an interceptive orthodontic procedure. We are also having some disadvantages with serial extraction procedure. Number one is proper judgment is required. Which patient can be carried out or in which patient serial extractions can be carried out successfully, and in which patient the serial extraction is going to complicate the condition should be judged properly by the clinician. This can be made out by proper arch length and tooth material discrepancy analysis. Okay. Now, as I told you, serial extraction is a process which involves a sequential extraction of the teeth, or a sequential extraction of few teeth at timely intervals. So the duration of the process is a very prolonged one. Say it might be carried over 2 to 3 years. In between one appointment to another appointment, a patient might actually skip the procedure, thereby complicating the condition rather than making it better. That means, as the process is carried out over a prolonged period of time, there might be patient dropouts, which will be harmful to the patient. That means the dentition will be disturbed rather than getting better. And patient cooperation is needed to carry out a serial extraction. It's always harmful to carry out a serial extraction in uncooperative patients, and it is not advised. Now, as I told you, we are going to extract a few teeth in serial extraction procedure. There will be actually gap left over between upper and lower arches, and the tongue might go and sit in that gap, leading to development of a tongue thrusting habit. Okay, and sometimes the serial extraction procedure might lead to deepening up of the bite, particularly when we go for extraction of deciduous first molar as a process of serial extraction. Now, there will be a risk of arch length loss. Sometimes into the extraction space, rather than physiological migration of the teeth into that extraction space as is anticipated, sometimes what happens is the adjacent teeth to the extraction space might drift by tipping movement, thereby reducing the actual arch length that is required for relieving the malocclusion. So these are the disadvantages of the serial extraction procedure, and you should be very careful while planning a serial extraction in any patient. Now, coming to the serial extraction procedure proper, different authors have proposed different methods of serial extraction, yet the basic rationale is the same that I have explained to you before. According to Duval's method, At around 8 to 9 years of age, we will extract the deciduous canines. By 8 to 9 years of age, there will be permanent centrals and laterals erupted in the oral cavity. With the extraction of deciduous canines around 8 to 9 years of age, which is the actual time period of eruption of the permanent canine, the crowded lateral incisors and central incisors will get adjusted themselves into normal alignment into that deciduous canine extraction space. 1 year later, we will go for extraction of the deciduous first molar. This will create sufficient space for eruption of the permanent canine in an uncrowded manner. Now, still later, once the permanent tooth, that is first premolar, erupts into the oral cavity, it is also extracted as a means of serial extraction procedure. Thereby, it will allow sufficient space for eruption of the canine and eruption of the second premolar. Thereby, a good occlusion will be achieved, and the crowding that was present in the region of the maxillary and mandibular anteriors will be relieved. There is one more method proposed by Tweeds. What Tweeds says is, the maxillary canine is erupted at around say 11 to 13 years of age or 11 to 12 years of age when compared to early erupted mandibular canine. Mandibular canine is erupted around 9 to 10 years of age, whereas maxillary canine is erupted around 11 to 13 years of age. So, according to Dewell, we are extracting deciduous canines first, and then deciduous first molar, and then first premolar. But as the time of eruption of maxillary canine is late, we can follow the Tweeds method in the maxillary arch, wherein we are first extracting the deciduous first molar, which will allow sufficient room for the erupting canine, and then once the first premolar starts erupting into the oral cavity, we will extract the first premolar also. Thereby, sufficient space will be present for eruption of the permanent canines, and at the same time for alignment of the crowded centrals and lateral incisors in the maxillary arch. So, in the Tweeds method, we first extract the deciduous first molar, then we will extract the erupting first premolar, and then we will extract the deciduous canine. So, we can follow Dewell's method of serial extraction in mandibular arch and Tweeds method of extraction in the maxillary arch. Yet, there is one more method of serial extraction proposed by Nance. This method is also same as Tweeds method, but in the Tweeds method, after extraction of the deciduous first molar, we will be waiting for eruption of the first premolar into the oral cavity for its extraction. But in Nance method, what we do is, we will extract the deciduous first molar, and at the same time we will enucleate the unerupted first premolar also. That is Nance method of serial extraction. Now, once the serial extraction process is completed, if at all some minor discrepancies in the dentition are present, that can be corrected by fixed orthodontics. That means sometimes into the extraction spaces created, the teeth might tip rather than moving bodily. Thereby their axial inclinations or axial inclinations will be changed. In order to optimize their axial inclinations, sometimes after the completion of serial extraction procedure, we need to go for a short span of fixed appliance therapy, thereby adjusting the occlusion to a more optimal one. Okay, you can just follow the animation of serial extraction. The deciduous first molar is extracted, premolars come into occlusion, and they are also extracted, which will allow sufficient room for eruption of the second premolars, and mainly the canines are provided much space to erupt, and the occlusion will get adjusted into a more optimal form. Now, the next important process of intercepting a malocclusion is developing anterior crossbites, correction of developing anterior crossbites. Now, what is the problem with the anterior crossbite? Anterior crossbite is supposed to be an emergency malocclusion. The best time to treat it is the first time you see it. That means it should be treated as early as possible. Why? First one is, it is a self-perpetuating one. Once a crossbite has occurred, then the mandible will go into an unrestrained growth pattern leading to a skeletal class 3 malocclusion. Okay. Presence of a reverse overjet or a crossbite will lead to inhibited growth of the maxilla and unrestricted growth of the mandible, leading to development of a simple crossbites into a more complicated skeletal malocclusions. That is why, as you come across a crossbites in the anterior region, you have to treat them at that point of time to prevent it from becoming a more complicated class 3 malocclusion. Now, what are the means of correcting a developing anterior crossbite? The first thing is, you can go for a tongue blade therapy. The child can use a tongue blade, a wooden tongue blade, to pull the maxillary incisor labially, as you appreciate through this image. So the tongue blade is placed just behind the maxillary incisor or maxillary tooth, the maxillary anterior tooth that is in crossbite relationship, and the patient can gradually apply a labially directed force onto that tooth. Thereby, the tooth that is developing into a crossbite relationship will get corrected itself into an optimum overjet and overbite. We have some removable appliances like Catalan's appliance, which is nothing but a anterior inclined plane in the lower anterior region. So every time the patient bites onto this anterior inclined plane, it will produce a forwardly directed force on the maxillary tooth that is in crossbite relationship, thereby correcting the developing anterior crossbite. So this is another method of correcting the anterior crossbite using removable appliance with double cantilever springs like Z spring. Activation of the spring will push the incisors, the maxillary incisors labially, thereby correcting the developing anterior crossbites. Okay. Now, the developing anterior crossbites might also be due to something called as functional shift of the mandible. If a patient has occlusal prematurities or high points in the restorations, then every time the patient bites from postural rest position to habitual occlusion, due to presence of occlusal prematurities, the patient will be habituated to bite in a more forward position, leading to aberrant forces on the dentoalveolar structures and mimicking a class 3 situation. Here, we need to eliminate the occlusal prematurities or high points or enamel pearls that might be present on the occlusal surfaces of the posterior teeth, thereby preventing the functional shift of the mandible, which might lead to a more complex class 3 malocclusion. Okay, this process of reduction of the tooth structure that interferes in the path of occlusion or reduction of the restoration that interferes with the occlusion, the process is called as occlusal equilibration. So, occlusal equilibration is one of the interceptive orthodontic procedures to prevent or to intercept a developing class 3 malocclusion or developing anterior crossbites. If the anterior crossbites are not dental one, if they are skeletal anterior crossbites, then we can use an appropriate orthopedic appliance or functional appliance to prevent its further aggravation into a more complicated skeletal class 3 malocclusion. Okay. Now, yet another important process of interceptive orthodontics is interception of the habits. As we have discussed in our lecture on oral habits and their complications or their effects on the developing dentofacial structures, we need to appropriately intercept the oral habits at appropriate point of time to prevent any aberrant development of the dentofacial skeletal structures. So you know the abnormal habits that are mainly implicated in the malocclusions are thumb sucking, tongue thrusting and mouth breathing habit, which has to be appropriately managed by using appliances like tongue grip to prevent the tongue thrusting and thumb sucking habit, and oral screen to intercept the habit of mouth breathing. Now, apart from these procedures, we have something called as space regaining. Usually, we will try to regain the space that has been lost due to mesial migration of first permanent molar. Suppose if a deciduous second molar is exfoliated well before its scheduled period of exfoliation, then the permanent first molar, which lies immediately behind it, will always have a tendency to migrate mesially into the space created by premature exfoliation of deciduous second molar. Now, the space lost due to mesial migration of the permanent first molar can be regained by distally moving the permanent first molar that has been tipped into the exfoliation space. This method is called as space regaining, and the space regaining can be done with number of appliances that are available. Let us see some appliances. So the early loss of deciduous second molar will cause mesial migration of the permanent first molar into the exfoliation space, thereby encroaching the space that should be preserved for eruption of second premolar. Now, we need to regain the space that is lost by mesial migration of the permanent molar by tipping it or moving it distally by using appliances called as space regaining appliances. Here we have a Gerber space regainer. In this kind of space regaining appliance, we can have a crown or band onto the deciduous first molar, to which a rod formed into the shape of U is soldered, and at the ends of it we are placing open coil springs. We are compressing the open coil springs and placing between those rods that are soldered to the crown on the deciduous first molar and mesial aspect of the molar. These open coil springs will tend to move the first permanent molar distally, thereby opening up of the lost space. This is one space regainer, and we have a space regainers like split acrylic plate with the jack screw. We can fix the jack screw in this manner as you see in the image, and gradually activating the jack screw will push the mesially migrated permanent first molar distally, thereby creating the space or opening up of the lost space. And we can also use the space regaining, we can also achieve a space regaining by using removable appliances incorporating cantilever springs like finger spring. So that was about regaining the lost space to intercept a developing malocclusion. The next important interceptive orthodontic procedure is muscle exercises. As we all know that muscles play an important role in the development of the dentition and craniofacial structures, we need to train the muscles to optimally function. We have exercises for masseter muscle. We need to clench the teeth while counting the time. Okay. This exercise will strengthen the masseter muscle, thereby it will aid in optimum development of the craniofacial structures with which it is related. Now, exercises of the lips. We can stretch the lips to maintain the lip seal, particularly the upper lip, or we can hold the water behind the lips and move it in a forward and backward direction, which will strengthen the lip and helps in establishment of the lip seal. And we can also have a button pull exercise or tug of war exercise, where we have a button which is tied with the thread. The button will be kept behind the lips and thread will be extending outside, and we will be trying to pull the thread, but at the same time we'll be preventing the button from being displaced from the mouth by holding it tightly with the lips. This exercise will strengthen the lips and helps in optimal development of dentofacial structures. Similarly, we have an exercise for tongue called as 1 elastic swallow, tongue hold exercise, 2 elastic swallow, and the hold pull exercise. Usually, we will recommend a 1 elastic swallow, wherein an elastic will be held against the palatal rugae, or an elastic might be placed on the dorsum of the tongue, and the child will be advised to swallow without displacing the elastic. This will help in training the tongue, particularly in the persons having tongue thrusting habit. Yet we have another kind of interceptive orthodontic procedure, that skeletal malformations which are developing. Usually, developing skeletal malformations will be due to aberrant muscle forces. So we need to apply optimum forces that are required for development of craniofacial skeleton, and at the same time we need to eliminate the deleterious forces that are acting on the developing craniofacial skeleton in order to prevent a malocclusion from getting more aggravated. We can use functional appliances like Frankel appliance, which has vestibular shields and buccal shields to shield the effect of musculature on the developing craniofacial skeleton. This also comes under preventive orthodontic procedure. And sometimes we can use lip bumpers to prevent mesial migration of the molars, or to even to distalize the molars that have been mesially tipped into the exfoliation space by using lip bumper. So interception of class 2 malocclusion and interception of class 3 malocclusion comes under interceptive orthodontic procedure. For example, if a person is having more advanced growth of the maxilla when compared to mandible, we can use orthopedic appliances like headgears to restrict its growth. Whereas if a class 2 developing malocclusion is due to reduced growth of the mandible, we can use functional appliances to modify the growth of the mandible or to increase the growth of the mandible, thereby improving the interarch skeletal relationship. Similarly, if a patient is having a developing class 3 skeletal malrelationship, then we can use reversible headgear or face mask if the fault is with the maxilla, and we can use a headgear with the chin cup if the fault is with the mandible, to intercept the developing skeletal malocclusion. That means by appropriately interfering during the period of growth and development, by appropriately interfering the abnormal developmental pattern or growth patterns of the maxilla and mandible, we can actually intercept from an existing skeletal malocclusion from becoming more aggravating. Okay. Now, last but not the least important interceptive orthodontic procedure is a removal of any hard tissue or soft tissue barriers in the path of eruption of the teeth. For example, in some patients, the gingiva overlying the developing or erupting permanent tooth might be thick and redundant, and sometimes the thickness of the bone in the region of the erupting permanent tooth might be too much. At that time, we need to eliminate cut the portion of the gingiva that is thick and redundant, or even we need to trim some amount of bone to eliminate the resistance that is present in the path of eruption of the permanent tooth. Even sometimes we can see cysts and tumors or any kind of pathologies that are present around the permanent tooth that will prevent its eruption. So by removing the pathology or pathological structure that is present in the path of eruption of the permanent tooth, we can also eliminate or prevent or intercept the malocclusion from aggravating into a more complicated one. Okay, so these are the important interceptive orthodontic procedures that are carried out, but only after careful assessment and evaluation of the patient's dentition and craniofacial structures. Okay, when instituted properly, these interceptive orthodontic procedures can minimize the actual degree of malocclusion that can be seen, thereby reducing the time and reducing the difficulty that might be present in treating a more complex malocclusions. So, managing a developing malocclusion appropriately by appropriate interceptive procedures will actually reduce the risk of complicating the dentofacial deformity. Hope you all understood. Thank you.